بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I'm Nazik Elmalaika Hussein, a professor of pathology at the Faculty of Medicine and Health Sciences, Durman Islamic University. I welcome you, and our session today is about diseases of the small intestine. By the end of this session, I would like you to describe the pathology and pathophysiology of the following small intestinal conditions: the congenital anomalies of the small intestine, obstructive lesions, vascular lesions, and ulcero-inflammatory diseases of the small intestine, malabsorption and tumors of the small intestine. I will divide this session into two parts. Part 1 will include up to number 4, the ulcero-inflammatory diseases. Then the second part will include malabsorption and tumors of the small intestine. Specifically, I expect you by the end of this session to define Meckel's diverticulum, which is a congenital anomaly of the small intestine, including in the embryology of origin, and to recognize the gross and the histopathologic appearance of Crohn's disease and ulcerative colitis, which are inflammatory bowel diseases, and to list the characteristic small bowel biopsy features of celiac disease and Weddell's diseases, which are part of or causes of malabsorption, and to describe the principal manifestations of the common neoplasms of the small bowel. Number 1, at the left, you see the atresia or stenosis. Atresia is a complete blindness, absence of the lumen of the small intestine, while stenosis is just a narrowing, which can be due to many causes. Okay. In the diverticulum, there is a protrusion of the small intestine. Microscopically, it is lined by a mucosa crossing the serosa, an epithelial lining crossing the serosa. Heterotopic pancreas is another abnormality in which you find microscopically pancreatic tissue within the or in the submucosa of the small intestine. This pancreatic tissue can be active or not. A specific or a peculiar congenital abnormality is called Meckel's diverticulum. This is the Meckel's diverticulum. It's a failure of involution of omphalomesenteric duct. This is the embryonic origin of this Meckel's diverticulum. Failure of involution of the omphalomesenteric duct. It is usually located in the distal hilum. It has a rule of 2, because 2% of the population can present with Meckel's diverticulum. It is more common in males by 2 times than in females. It is located 2 feet from the ileocecal valve, and it contains 2 types of epithelium: gastric and pancreatic. This is the ileal side of the Meckel, microscopically Meckel's diverticulum, and this is the gastric tissue of Meckel's diverticulum. There are many causes of intestinal obstruction, which is an acute abdomen. Some are hernias due to hernia, or adhesions, or intussusception, or volvulus. These are the common causes of obstruction, but other causes exist. This diaphragmatic representation differentiates between the hernia and adhesion. This is the hernia here at the right side. Also, this is an inguinal hernia, for example, and these are adhesions. Okay. Here is the intussusception. This is the hernia. This is adhesion. This is intussusception. The involvement, introduction or backgrowth of part of the intestine into the other part. Okay, intussusception. This is it. Intussusception. Here is a volvulus. Both volvulus or intussusception or hernias sometimes cause to ischemia, and this leads us to study what is ischemia, what are the conditions that can cause intestinal ischemia. Other conditions are arterial thrombosis, which can be due to atherosclerosis or vasculitis, and arterial embolism, which can be due to vegetations, rheumatic fever, for example, or venous thrombosis due to the different hypercoagulable states. Or the cause of ischemia can be non-inclusive, like shock. Shock can cause ischemia. Other miscellaneous causes like volvulus, hernia, and intussusception also can cause ischemia. This is the ischemic lesion of the part of the intestine, with sharp determination between the viable and non-viable part of the intestine. Microscopically, this is the normal area of the small intestine with villi like this, which are containing red blood cells. At this side, there is absence of the normal villus appearance. There is inflammatory tissue, increased inflammatory cells, total distortion of the structure, absence of the crypts, which are here, and here there is also a sclerosing part of the chronic inflammatory process due to ischemia. Inflammatory bowel diseases of the small intestine are common and caused by ulcerative colitis and Crohn's disease. This diagrammatic representation shows the difference between ulcerative colitis and Crohn's disease. In ulcerative colitis, the affected lesion is usually the distal part of the colon, but backflow in the ileum can occur. While in the Crohn's disease, there is skip lesion, there is intermittent lesions, and most commonly in the intestine. Crohn's disease can affect any part of the small intestine from the mouth to the anus, while ulcerative colitis mainly affect the distal part of the colon. Okay? Small bowel diseases are conditions with chronic recurring immune response and inflammation involving GI tract. So the pathophysiology of inflammatory bowel diseases is an immune response and inflammation involving the GI tract. The immune system mistakes food, bacteria, and other materials for destructive foreign substances and attacks the cells of the intestine with chronic inflammatory infiltrate. In Crohn's disease, the etiology is most likely multifactorial. That is to say, there is an inflammatory trigger in a predisposed individual. There is an increased incidence in Northern Europe, United States, and the Jewish populations. There are two peaks. The major peak is in the 20s to 30s, and the smaller peak is in the 60s to 70s years. Smoking exists with increased risk of recurrence and relapse. Crohn's disease is associated with a perinuclear anti-neutrophil cytoplasmic antibodies, which are called B-ANCA, the first letter of each of these. Perinuclear, the P, anti-neutrophil cytoplasmic antibodies, as seen here, with fluorescent cytometry. And this ANCA, B-ANCA, is more common in ulcerative colitis than in Crohn's disease. Both ulcerative and Crohn's are inflammatory bowel diseases. Non-GI involvement occurs in 25% of Crohn's disease, and this can present as in the joints and arthritis, inflammation of the joints, or arthralgia, pain in the joint, or ankylosing spondylitis. There are other intestinal manifestations. There is in the liver a primary sclerosing cholangitis, as here, primary sclerosing cholangitis, okay, here, which is also common in ulcerative colitis rather than Crohn's disease. Anatomically, Crohn's disease can involve any part of the GI tract, from the mouth to the anus, as we said, but mostly ileocolonic involvement. 10 to 30% show upper GI involvement. Characteristically, there is rectal sparing. The rectum is not involved in 50% of cases of Crohn's disease, while the vice versa. In ulcerative colitis, the distal colon, including rectum, is mostly affected. A characteristic feature to remember is the skip lesion. Skip lesions, which are abrupt transition between the involved and uninvolved bowel, leading to a macroscopically appearance called Copeland stone pattern. This is in a closer view. These are the Copeland stone caused by the skip lesions. Skip lesions, the inflammatory condition, affects part, not a continuum, of the small intestine part, and escape the other. These are the normal ones, cause the Copeland stones pattern. The formation of strictures, or there are some complications of Crohn's disease. It can be complicated by formation of strictures, fistula, adhesions, serositis, inflammation, acute inflammation of the serosa, serosal exudates, and periintestinal inflammations. Here, this is an abscess formation, a representative diagram showing abscess and fistula in a patient with Crohn's disease. Microscopically, Crohn's disease you can find active colitis or chronic colitis. Okay? In active colitis, you will find cryptitis, inflammation, acute inflammation of the crypts with neutrophils, and crypt abscess formation, mucosal ulceration, inflammatory pseudopolyps, and inflammation involves all the layers. This is a very important information. The inflammation in Crohn's disease involves all wall layers, and it is called transmural inflammation. This is in contrast to ulcerative colitis, as we will see soon. In chronic colitis, there is increased lymphoplasmacytic lamina propria, lymphoplasmacytic lymphocytes and plasma cells, which are the inflammatory cells of the chronic inflammation. In the lamina propria infiltrate. These are lymphocytes and plasma cells like this. Mainly here, these are lymphocytes and plasma cells, dark, small lymphocytes. Pseudopyloric glands and gastric surface, alveolar metaplasia, penicell hyperplasia, small bowel and right colon, and penicell metaplasia, mainly in the left colon. As you see here, there's widening also of the crypts and branching. Microscopically, as we said, there is a transmural linearly distributed lymphoid aggregates called strings of beads, and there is non-necrotizing granulomas. These are granulomas with characteristic giant cells. They are non-caseating granulomas, not like those of the tuberculosis. Okay, these are the lymphoid aggregates, linear lymphoid aggregates, strings of beads. Architectural distortion of the crypt drop out. You will not find or see them. Branched, dilated, irregular crypts, as we saw in the previous slide. Crypts no longer reach the muscularis mucosa, become shortened. Clinically, Crohn's disease can present with variable abdominal pain, diarrhea, and malabsorption. It can be inherently indolent with non-perforating, slow recurring, or inherently aggressive. There is a great variation in the clinical presentation of Crohn's disease. The aggressive one can present by perforated intestine and rapidly evolving. Crohn's disease can be complicated by, as we said, perforations in 1 to 5% of cases, fistula tracts, abscesses, obstruction due to stricture, and toxic megacolon, which commonly leads to death, the cause of death. Importantly, Crohn's disease can be complicated by a dysplasia or carcinoma in 5% of patients. They will develop carcinoma. Small bowel cancer in Crohn's disease is 10 to 20 times increased risk. The treatment of Crohn's disease can be by corticosteroids or other immunosuppressive drugs, or surgically. In most patients undergo some degree of resection to reduce the clinical features. The other inflammatory bowel disease is ulcerative colitis. The definitive cause is not known. It is an idiopathic disease. It is common in females than males, with increased incidence in European descent, but it is also present in Sudan. There are cases of ulcerative colitis in Sudan. There are 3 peaks of incidence: early 20s, early 40s, and early 60s. Ulcerative colitis is associated with perinuclear antineutrophil cytoplasmic antibodies more than Crohn's disease, as we said previously. It also can present with extra GI symptoms like arthralgias and primary sclerosing cholangitis, also more in ulcerative colitis than in Crohn's disease. Note that 50% of ulcerative colitis patients have primary sclerosing cholangitis, and 70% of primary sclerosing cholangitis patients have ulcerative colitis. There is a strong association between the two conditions. Anatomically, ulcerative colitis classically involves only the colon, and there is contiguous involvement without skip lesions, continuous involvement by the inflammation. Rectum usually involved, while only a few cases in Crohn's disease are involved the rectum. Backwash ileitis, inflammation that backwashed, and appendiceal involvement can occur in continuity with pancolitis, inflammation of the whole colon. No strictures, fistulas, serositis, or fat trapping complicate ulcerative colitis like those in Crohn's disease. Anatomically, also we can see acute or chronic changes. In the acute changes, the mucosa, erythema, and bleeding can be obvious. Or oozing shallow ulcers, not deep fissuring ulcerations like Crohn's, okay? The ulcers in ulcerative colitis are shallow ulcers. The chronic changes are loss of normal vascular pattern, loss of mucosal folds like Crohn's, and mucosal granularity. Here again is the microscopic appearance of ulcerative colitis. They are similar to each other with minor changes. The transmural inflammation or ulcers, the granuloma in Crohn's. And Crohn's is skip lesions, okay? Right. Active colitis include cryptitis, crypt abscess formation, mucosal ulceration, inflammatory pseudopolis. And chronic colitis involve increased lymphoplasmacytic infiltration of the lamina propria, architectural distortion, branched dilated irregular crypts, dilated crypts no longer reach the muscularis mucosa, and penicil metaplasia in left colon. Clinically, ulcerative colitis also present with abdominal pain, diarrhea, urgency, and weight loss. Classically characterized by periods of remission and relapse, which are called ulcerative flares. Distal disease or proctitis at presentation can occur and may continue as limited or may spread. Ulcerative colitis can be complicated by a very characteristic complication called toxic megacolon. Toxic megacolon. Megacolon is the dilated colon with decreased motility and thinning of the wall. Another complication is colitis-associated dysplasia, markedly increased risk of dysplasia, and 1 to 2% risk of carcinoma each year. So both ulcerative colitis and Crohn's disease carry a risk of carcinoma. The treatment also is corticosteroid or other immunosuppressive drugs, or surgical definitive operation, total abdominal colectomy with ilio-pouch anal anastomosis. This is characteristic here. We do not need usually this in Crohn's disease. Okay. This is a column. In this picture, there are 3 columns, and they show the differences between Crohn's and ulcerative colitis. At the far left, this is the normal appearance or diagrammatic representation of the small bowel. Okay, and this is the normal microscopic appearance or histology of a normal specimen with intestinal folds like this. And this is the normal appearance of the endoscopic view of a normal small bowel. In the middle, it shows the features of Crohn's disease. In the representative diagram, it shows a thickening of the wall of the small intestine and fat trapping. Okay. Inside, there is coupling stone appearance and a fissure which is transmural ulceration or inflammation. This is the fissure, transmural, and this is the thickened wall. And at the bottom of the middle, this is the appearance, the endoscopic appearance of Crohn's disease, showing the coupling stone appearance. The normal areas appear raised other than the diseased one. At the right side, this is the ulcerative colitis, showing ulceration inside, and the surviving mucosa shows pseudopolyps due to the surviving or caused by the surviving mucosa. There is loss of hostra, and microscopically there is a great crypt distortion. Compare it with the normal. In both of them, there is a structural destruction of the normal histology. In ulcerative colitis, a marked distortion of the villi, the crypts. Okay, and in the endoscopic appearance of ulcerative colitis, you see pseudopolyps. As we said, it is due to the surviving mucosa. We stop here, and we will. I will stop here and send you this video. Next one will be about the tumors and malabsorption. Wassalamu alaikum wa rahmatullahi wa barakatuh.